Hi everyone, welcome back to today's video, and in this video we will be talking about missed abortion. So before starting with missed abortion, let's see what actually abortion means. So abortion means loss of pregnancy before 20 weeks of gestation. If the loss of pregnancy happens after 20 weeks of gestation, it is called stillbirth. It is not called abortion. So in the question in the exam, if you see a question that says the pregnancy, the gestational age is more than 20 weeks, so all the abortion options are ruled out. So it is not a case of spontaneous abortion or abortion. It is stillbirth. So let's go to missed abortion. What do we mean by missed abortion? So there are two scenarios. First is the baby has died in utero. That is missed abortion. Second, the baby has failed to develop in utero. That is also missed abortion. So in the second case, when the baby has failed to develop in utero, although the fertilization happened, the gestational sac developed, yolk sac developed, still the baby failed to develop in utero. That is also missed abortion. So we will see two characteristic findings on ultrasound in this case. First is the gestational sac will be more than 25 mm in diameter, but it will have no fetus. It doesn't contain fetus. So a gestational sac of this size, that is 25 mm or more, should have a baby inside of it, should have a fetus inside of it. But if it is not there, that means it is a missed abortion. The baby has failed to develop in utero. Second is that if the fetus is 7 mm or more in diameter, but it doesn't have a cardiac activity, then it is also missed abortion. So this is a scenario where the baby has failed to develop in utero. Now coming to the second scenario, when the baby has expired in utero. So how the woman will present in that case? Clinical presentation of the missed abortion. So she may come to you with very vague symptoms or no symptoms at all. She will come and say that I have a little bit of vaginal bleeding or I don't have a vaginal bleeding. I have a little bit of abdominal cramp. But the main complaint will be that I am not feeling the baby inside of me. I am not feeling any fetal movements. I am not feeling any kicks. Baby is not kicking me. Or I think that the uterus is not growing appropriately in size. So you do a physical examination. What you will see on a physical examination? You will see that uterus is smaller for gestational age, depending on whether the abortion has happened recently or it has happened long back. If it has happened long back, then the discrepancy will be much larger. The uterus will be very small as per the gestational age. Or if it has happened recently, like it has happened 2 or 3 days back, and you are doing a physical examination today, then uterus will be consistent in size. So it depends on the time period. Another thing you will see is that cervical os will be closed. So in missed abortion, cervical os is closed although baby has died in utero. So at this point I want to mention that there are only two types of spontaneous abortion in which cervical os is open. Both starts with I, that is inevitable abortion and incomplete abortion. So we will be discussing about incomplete, inevitable, threatened abortion, all the different types of spontaneous abortion in another video. But let's concentrate on missed abortion in this video. So cervical os will be closed in missed abortion. So when you check the beta HCG, coming to the labs, when you check the beta HCG, what you will see? Beta HCG will be lower than expected. So in healthy pregnancy, beta HCG doubles every 48 hours. Every 2 days, beta HCG doubles. But in case of missed abortion, because baby has expired, beta HCG will not double in 48 hours. It will be lower as compared to gestational age. Like what is appropriate for gestational age? It will be lower than that. So now you do an ultrasound to confirm your findings. What you will see? You will not see any cardiac activity. You will not see any fetal movements. You will not see any fetal heartbeat. So these are the findings of missed abortion, and they are pretty obvious because baby has died in utero. So how can you see any cardiac activity, or how can you see any fetal movement? How can you feel the heart of the fetus even by ultrasound? So these are the findings of missed abortion. So let's revise. Patient may be asymptomatic or may have minimal vaginal bleeding, minimal abdominal pain. She will have vague complaints and she will say that I am not feeling the baby inside of me. Uterus is not growing appropriately and I think something is wrong. That is a clinical presentation. Now you will do a physical examination. Uterus will be smaller in size compared to the gestational age, and cervical os will be closed. Coming to the labs, you will see the beta HCG, which is lower than what is appropriate for gestational age. You will do an ultrasound. You will not see any cardiac activity, and you will not see any fetal movement. And if the baby has not developed at all, you will see a gestational sac more than 25 mm in diameter, but there is no fetus inside it. Or you can see a fetal pole greater than 7 mm, but there is no cardiac activity. So this is in all the symptom and presentation and investigations of missed abortion. Coming to the management part. So what you will do first when a mother whose baby has aborted inside of the uterus, you will do first? First step will be counseling. You will console the mother. You will not just start with medications or anything like the management itself. You will first counsel the mother. You will console the mother. You will provide the emotional support. Then what will you do? You will tell the mother that you wait for 4 to 6 weeks and baby will be expelled naturally, most probably. So you will not do anything. You will tell the mother that you can wait for 4 to 6 weeks, and in most cases, babies are expelled naturally. What this is called? This is called expectant management. So the approach is called expectant management, in which you don't do anything. So why we do the expectant management? We should be doing something. We can do dilatation and curettage. We can suck out the baby out of the uterus, but we don't do that. Why? The reason being, the uterus is very vulnerable right now. There can be a risk of infection if you do anything. If you insert any instrument or you do anything with the uterus or the cervix at this point, there can be risk of hemorrhage. There can be risk of infection. So that is why you don't do anything and you let the baby pass out in 4 to 6 weeks automatically. You send the mother home. Now, are there any conditions in which you don't do the expectant management? Yes, there are some conditions in which you don't do the expectant management. What are these? If the mother is at the risk of hemorrhage, if she is on any anticoagulation, if there is any history of thrombophilia. So these are the conditions in which the mother is at the risk of hemorrhage. So you don't do the expectant management because she may go home and there she can have the bleeding, the hemorrhage, and she may go into shock. So you don't do these things in these cases where there is a risk of hemorrhage. Another condition, if she lives very far away, if she cannot come for a follow-up, then you avoid expectant management. Okay. So coming to the medical management, if you don't want to do the expectant management, if you don't just want to observe or send her home, what you will do? You can give two drugs, misoprostol and mifepristone. And these drugs, what they will do? They will soften the cervix. So when they soften the cervix, it is easier for the baby to be expelled out. It is actually kind of supporting the expectant management. In expectant management, we don't do anything. But in medical management, we give these two drugs, misoprostol and mifepristone, so that the cervix gets softened and baby can be expelled out easily. Now, baby can only be expelled out by itself if it is smaller. Larger baby cannot be expelled out automatically or by softening the cervix. So we prefer expectant management or medical management if the gestational age is less than 12 weeks of age. Otherwise, we will go for surgical management. So coming to surgical management, there are two kinds of surgical management. One is suction curettage, another is dilatation and curettage. So suction curettage, we will just suction out the baby. In dilatation and curettage, we will dilate the cervix and suction out the baby. So when do we need the dilatation? When the baby is bigger. So suction curettage is done in less than 12 weeks of gestational age. Dilatation and curettage is done when the baby is bigger, that is more than 12 weeks of gestational age. So this is the management of missed abortion. One thing I want to mention in missed abortion is that you always rule out the ectopic pregnancy. If a lady comes to you and she says that I'm not feeling the baby inside and I'm not feeling the cakes and beta HCG again is not rising appropriately. So can this be an ectopic pregnancy? Yes. So the clinical presentation, the labs and everything is very similar. And this is more important if the mother is coming to you for the first time. If she is coming for the second or third time, then you have seen the baby inside the uterus before in previous visits. But if she is coming for the first time and she presents with these vague symptoms, then there is a possibility that there was no fetus inside the uterus. It is in the fallopian tube or some other ectopic site. So you will rule out the ectopic pregnancy, especially when if the pregnant lady is coming with this presentation for the first time to you. So why it is important to rule out ectopic pregnancy? Because it is an emergency. It is a medical emergency. Ectopic pregnancy can rupture. That's why in missed abortion, you will always rule out ectopic pregnancy. So that's for today. That's for missed abortion. I hope you like this video. If so, please like, share and subscribe, and I will see you in the next video. Signing off. Bye.